Please. Hi, welcome everyone. My name is Sally Sattel. I'm a resident scholar at AEI, and this is a discussion of the new asylum, that is jails and prisons that house the severely mentally ill, who, as everyone knows, would do much better in a bed than in a cell. Last year, actually, there were an estimated 90,000 inmates who did not go to trial because they were so psychotic, so mentally ill, they couldn't even understand the charges against them. So in short, they were incompetent to stand trial. And the place for people like this, where they should go, is something called a forensic bed in a hospital facility where they get treated and are brought to the point where then they can participate in their own trial and their own defense. But unfortunately, these beds are in terrible shortage. There's a critical lack of them, and so that means these folks stay in jail or prison. The longer they stay, often the more psychotic they get. You can imagine the treatment isn't very good, and this opens them up to assault, sexual and physical, and worsening of their own situation, and also suicide. In fact, suicide is the largest reason for deaths in jail. So this is a terrible situation. And luckily, a new report called Emptying the New Asylums, Bed Capacity Modeling to Reduce Mental Illness Behind Bars has just come out from the Treatment Advocacy Center. It's an evidence-based approach for reducing this crisis, and I honestly think this is a groundbreaking report based on a novel modeling approach that will break the logjam, and is already starting to break the logjam of mentally ill in our nation's jails. It's finally a relief to talk about a solution that really can work and is working. So we'll start with the first speaker, who is a co-author on this report, Doris Fuller, who will describe the findings against the backdrop of criminalization of the mentally ill. What I'm going to do is introduce everyone. Certainly I'm not going to do them justice with this brief introduction, but their bios are online and they're much more detailed. I have one unfortunate bit of news, which is to say that Mr. Pete Early cannot join us, situation that he could not, unfortunately, get out of. So he won't be with us, but we have 5 outstanding speakers. As mentioned, Doris Fuller here is the director of the Office of Research and Public Affairs at the Treatment Advocacy Center, which is close by in Arlington, Virginia. TAC is a public service agency. It's not an agency, organization. It's very, very private, very, very free to examine the questions it thinks are most important. And it's dedicated to increasing public access to important new research about the brain, behavior, and public policy. Doris will be followed by Kristen Licht, who's a research assistant professor with the Gilling School of Global Public Health at the University of North Carolina. Dr. Licht was part of the team that developed this queuing model, and she's going to describe it in some very user-friendly detail. And also, one of its great virtues is that it can be applied to many other social problems. Next is Judge Steve Leifman, Associate Administrative Judge for the 11th Judicial Circuit Court of Florida. He'll talk about the implications of the report for judges, and also talk about his award-winning success in Miami-Dade in keeping mentally ill individuals out of jail and prison. Following him is Matthew Chase, Executive Director of the National Association of Counties, which represents over 3,000 county governments. And he will talk about how how counties and county jails and also states will play a role in addressing these concerns. And he'll also talk about the great challenge of convincing politicians how important it is to spend some money up front so that you can reduce costs down the line. And anyone who works in Washington knows that is one heck of a battle. And finally, Mike Resendez, who is a reporter, an investigative reporter with the Boston Globe, who worked on a frankly heart-wrenching series. It must have been so painful for you to do this, on the mentally ill in prison and in Massachusetts in general. Will talk about that series, as well as, for all the pain, it was certainly had some positive outcomes because it did inspire Governor Baker to make some very important changes in the state. He will also provide, Mike Resendez will also provide some more information, some more aspect on the national scene for this. So now I'm going to open it to you, Doris.
Thank you, Sally, and thank you to the American Enterprise Institute for having us here today. And thank you to my fellow panelists who I am relying on to put flesh on the bones that I will go over to begin with. I also want to acknowledge briefly that two of the co-authors of this study, Elizabeth Sinclair, our research associate, and John Snook, our executive director, are in the room. Out of the room, two other authors, very important, Dr. Richard Lamb, who was a pioneer in researching the criminalization of mental illness. He's been reporting on this for decades. And Judge James Casey of the King County Judicial Court in Seattle. He was a pioneer of mental health courts. And so these are the authors of this study. So by the end of today, if it's an average day, another 5,000 people with serious mental illness will be booked into American jails. Most of them will be arrested for crimes that don't make headlines. They'll be arrested for trespassing, vagrancy, urinating in public, nuisance crimes, many for low-level felonies, some for violence. Because of those crimes, which are largely driven by untreated symptoms, we have a population of inmates behind bars in America today with mental illness that's about the size of the city of Oakland, California. It's not a small population. So emptying the new asylums, which is the title of this program and the title of our study, began as a vision at the Treatment Advocacy Center to find some practical approaches to reducing this problem. And the results were so startling, even we were surprised. That doesn't happen very often. Usually when you have a hypothesis, you have some idea of what you're going to find. This proved to be even more surprising than we thought, which was that startlingly small practical changes, relatively low in cost, could dramatically reduce America's mass incarceration of people with psychiatric disease. So we've started this project. I'll give you a tiny bit of background before I tell you what we found. The project started almost a year ago when I traveled to North Carolina to meet with Dr. Litch. Dr. Litch was on a team from the University of North Carolina and Duke University that developed a beds capacity model to look at reducing psychiatric boarding in emergency rooms, another major crisis we have in America, people waiting for days or weeks for a psychiatric bed in an emergency room. So they worked on a model, a computer model, to see how you could reduce, how many beds they'd need in North Carolina to get this number, to get the waits down to 1 day or less. When we saw that research at the Treatment Advocacy Center, we immediately said, could we do the same thing for forensic beds, for all these people waiting in prison, in jails rather, not prison, to be tried, but who are mentally ill? And so today's program, for which we are enormously grateful for AEI to bring to you and the public watching online, is an outgrowth of that vision. So I have a few slides to share with you and some findings. So, and I have the clicker. All right, so let's look, I want to take a minute to look at the background. How did we get here? Why are we talking about jails as the new asylums? Okay, so we have an estimated 8.1 million adults in America that have serious mental illness, as we're defining it in this talk and in our study, which are people who have such a disabling condition, it puts them at high risk to be involved with the criminal justice system or the civil commitment system. From that population, we get about 1.8 million jail bookings a year. That's those 5,000 a day I was telling you about. And we get our 383,000 adults with mental illness behind bars, or about 20% of the US jail and prison population. And there's an interesting statistic here. 3.3% of the population of adults is accounting for 20% of the jail and prison population. This is a disparity that needs to be addressed. It also needs to be addressed that at the end of the day, 40% of people with a serious mental illness end up incarcerated at some point in their lives. How did we get here? In one slide summarizing 50 years of public policy, you see the chart, a picture is worth 1,000 words on your left. Trying to do it, is it my left or your left? The bright blue line is the number of psychiatric beds in state hospitals in America. The dark blue line is the number of people with mental illness in jails and prisons. It's interesting that and then of course the detail that in all but 5 states in the United States today, we have more people with mental illness in jails and prisons than in psychiatric beds. 10 times more. We have more than in a jail or prison than in the largest state hospital in 45 states. So we've basically taken this population and moved them from the old asylums, which were state hospitals, into the new asylums, which are jails and prisons. And for the record, this is actually considered in academia to be a fairly controversial theory. That's a debate for another day. What's not a debate is why these hospitals matter, why the state hospitals in particular matter. And that's because for a lot of, among other reasons, the forensic patients, the people we're talking about here, have to go to a state hospital. They can't be taken to your general community hospital after their arrest for the services they need. So they have to go to the state hospital. So as Sally mentioned, we have about 90,000 people, estimated 90,000 people with mental illness behind bars today. If you talk to sheriffs in a lot of counties, and Matt may address this, some of them will tell you they have far more than 20% of their jail occupied by people with mental illness. Most of those are legally incompetent to stand trial. This doesn't mean that they're so well they can walk out and get a job tomorrow. This means they meet the constitutionally guaranteed standard for being legally able to go to trial and defend yourself and talk to your counsel and understand the charges. 90,000 people. By the way, these people and so what they're entitled to is an evaluation to see if they are competent to stand trial, and services to restore their competency. Legally, in most states, those services can be provided outside of a hospital. In some states, they can be evaluated in the jail, or they can be restored in the community, or they can be restored even in the jail. There are a lot of options. Despite the options, state hospitals remain the default location for these services. And how many beds do we have left for them? About 8,800. 8,800 forensic beds that are available for the pre-trial defendants. Basically, this comes from, we've got about 37,500 beds left in America in state hospitals. Half of those are forensic beds. Half the forensic beds are occupied by people who are not guilty for reason of insanity or are hospitalized otherwise for a long time. So what happens to our inmates who are waiting to go to trial? They're too sick to go to trial. They haven't been convicted. They haven't been tried. What happens to them? Well, with 8,800 beds, they wait. They wait a long time. Most waits are around a month. Can you imagine if you were taken to the ER and you had symptoms of cardiac arrest, and the deal was you had to wait a month to get a bed? Most wait around a month. There are states with years, those waits that are as long as a year, 9 months to a year. Now, what happens to them while they're there? Only 17% of them get treatment. So 4 out of 5 are sitting there. They are sick. They are acutely ill. They are not being treated, and they are waiting for a bed. As Sally alluded, suicide is the leading cause of death in jails, but there are many, many other ways that this population suffers in jail. The outcomes are terrible. They get worse, for one thing. They get victimized. They have to stay longer in the hospital when they get there because they are sicker. And they're not the only ones impacted. Matt, I know you'll appreciate that I used your slide. But, and I hope you don't mind, but NACO did a survey in 2015 of what are the challenges facing corrections systems in America today. Well, guess what? Their number one challenge is reducing the number of people with mental illness behind bars. Number two is coordinating mental health treatment. Wow. Number three, reducing jail costs. Number four, reducing jail populations. Guess what? Reducing jail costs and reducing jail populations is very related to reducing mental illness in the jails. And fortunately, we have Judge Leifman here today who will give us a very dramatic real-world example of how that works. So, and the impact on taxpayers. It goes without saying, this is really an expensive way to approach serious mental illness. County governments spend about $8 billion a year on pretrial defendants. That's about 450,000 defendants a year, of whom 90,000 are mentally ill. But the thing is, all defendants are not equal. The cost for a mentally ill defendant pretrial in jail, 2 to 3 times the cost for the other defendants. So this is a high cost area for our jails. So we have these terrible impacts. And so I reached out and talked to Dr. Litch and said, can you come up with an evidence-based computer model that might produce different results without requiring a complete massive rebuilding of the hospital system in America, which we know won't happen? And so she said, yes, we can do that. And so we asked ourselves 3 questions to get to some answers to say, okay, so how would we do that? We said, well, what if there were fewer people being arrested and added to the bed wait list? What if we just had and I heard that chuckle. Oh, he can't wait to get started. He's going to tell us in the real world what that looks like. And then what if average state hospital stays were not being extended for non-clinical reasons? And what I mean by that is we do not have a problem in this country with people not being hospitalized too long for psychiatric problems. On average, they're booted out in about 5 or 6 days. This is not true of forensic patients, but in the state hospitals, we do have situations where we have we have large populations of people, for example, who are ready to discharge, but we don't have any place in the community to discharge them to. So they're taking a bed. And we have our NGRIs and others who have very long hospital stays, and as they stay longer, the people who need a bed for a shorter period of time have to wait for that bed. So what if the non-clinical, the administrative, the bureaucratic reasons that people stay as long as they do could be tweaked? Would that make a difference? And then finally, of course, what if there were more beds? We can't talk, at the end of the day, we don't have enough beds. We need to talk about more beds, but how many do we need? We don't have good targets. We don't have good research. If you're a county or you're a state and you're saying, well, how many beds would we need to get this problem under control? We don't have the models that people are using to get to that. So those were the questions that we asked ourselves. And the bottom line, which we will come back to over and again, is that it turns out relatively small changes in common practices can have dramatic results that reduce the human and the economic toll of of this problem of the new asylums. So how small and how dramatic? Well, we modeled data. We gave the University of North Carolina data from 5 states, and they modeled it. So here's a sample finding from your state. So what we found in Florida, using this is early 2016 data, that they've got about 120 inmates reaching the jails per month and going on to the waiting, that are going to need IST services, that need their competency restored before they can go to trial. And it turns out, if you divert 2 of them, the average bed weight drops from 12 days to 3 days. I'm so glad that Dr. Litch is here to explain how this happens, because we kept looking at these numbers and saying, really? Here's an example from Texas. Okay, I mentioned length of stay, how long people stay in the hospital. We want people to stay long enough to be restored and to be stable and be able to re-enter the community. But we don't want them staying for 2 extra weeks because they can't get on the judicial calendar, for example. So we found that if you reduced the length of stay in Texas by 2%, that's 3 days, 186 to 189 to 186, look at those numbers. The bed weight drops for the inmates that are sitting in the new asylum suffering at a very high cost to them and the rest of us. Drops from 2 months to 3 days. And one last little example. In Wisconsin, adding hospital beds. You add 8 psychiatric beds to their, those are forensic beds, to their existing supply of 70. What do you get? Average bed weights drop from 2 months to 2 weeks. It's kind of mind-blowing, actually. So I do want to say that this is a mathematical model. It is a computer model. It may not always behave the way the world does. The world is populated by humans, and humans are not always mathematical in their approach to things. However, this shows us what the potential is. This creates an evidence-based tool for addressing a problem that we thought was intransigent and also unbelievably expensive. Some of the recommendations we make, which we'll come back to much later, we're not talking big ticket recommendations to make a difference in people's lives. And so with that, as I said, I'm so delighted to pass the baton to Dr. Litch, Dr. Kristen Hassmiller-Litch from the University of North Carolina. Are you reintroducing her? Mm-hmm. Okay. Because although I could try to explain why it works like this, she is the expert, and we are incredibly grateful for her participation in this project and for being here today. Take it away.
Thank you. Okay. So my goal is to give you a sense of what this model is all about, this decision support model, and some intuition for the results that we're seeing. So there's been some interesting research conducted over the past 20 years that's shown that we aren't very good at intuiting how dynamic systems behave. What do I mean by dynamic systems? I just mean that there are a set of factors that determine the outcome or the set of outcomes that we care about, and both are changing over time, often with delays between changes and the effects that they trigger. The topic of much of this research on how well we make decisions, supply chains are a great example of a dynamic system. So consider, for example, that you're sitting in the middle of a production and distribution chain that gets medication to patients when they need it. When trying to control a supply chain, when you're sitting in the middle of it, you want to have enough stock on hand to meet demand, but not too much, because that often comes at a cost, especially if we're talking about medications that have a short shelf life. So unaided, we're really terrible at deciding when to reorder and how much to reorder. We often end up over ordering and under-ordering, fairly wildly oscillating around what would be a better decision. So another example of dynamic systems is what we're here to talk about today, what I would call queuing systems. Queuing systems describe processes of waiting for and being served. We describe a queuing system by breaking it into 3 parts. The first part is the arrival process. It describes how people arrive to be served. We often talk about, as Doris did, how many people arrive to be served per day, week, month. It depends on how fast the system's working. Second, we describe the service process. So what does service entail? Is it one process or a series of processes? How long does each take? How many servers are there? Who goes to which one? In some queuing systems, servers are people. In our competency restoration example, the constraining factor here is often staffed beds. So we're going to consider those to be our servers. Finally, the third part of describing a queuing system is we describe the rules about how people wait. Typically, we talk about first in, first out. The longer you wait, the sooner you are going to get in. But it's not always the way it is. So sometimes people keep waiting. We wonder whether people keep waiting until they get in or not. Do they leave the queue? In our case, they're going to stay in the queue in jails. So these systems don't behave in a linear manner. Adding a server doesn't confer a fixed impact on wait times. It matters where you are, what your system looks like. So our intuition about how to fine-tune systems with too much waiting is often totally wrong. Decision support models can help. And basically what they do is simulate the parts, which can be studied and grounded in data, and our rules or assumptions about how things work. So how people arrive, what the service process looks like, and how people wait. The model is tracking what happens in terms of how long people have to wait, how busy servers are we using the servers that we have efficiently, and how much does it cost to run our system. Once we build a model of the current system, what we often call our status quo, we can use the model to test scenarios for change. What if service times were a little bit lower? What if demand was a little bit lower, if we could meet people's needs elsewhere and divert them from needing this service? What if we had an extra server? So I'm going to show you several examples of simulation models running right now, because I think this is the best way to give you an intuition for what's going on in these models. There's no magic, I promise. So let's start with the first video. Here, we're simulating a simple system, say a fast food restaurant, healthy, of course. One customer arrives every minute. They get into a single line and wait for the first available server to order and pay. No one leaves without ordering. It takes approximately 3.8 minutes on average for service. There are 4 servers. In this version of the system, the average customer is in the system, that's the total of waiting and being served, for a bit under 20 minutes. That means with just 4 minutes of time, just a little bit less than 4 minutes of time being served, they're waiting 15 to 16 minutes. If you run this model over and over, because there's randomness in here, the average time in the system varies between 18 and 22 minutes. So let's cue the second video. What would it take to make things better? The model offers us a chance to try out different scenarios before committing, before investing in change and learning the longer way. What if we add another server? Now we're looking at 2 versions of the system running at the same time. In both, customers arrive about every minute, 1 customer about every minute, and service still takes 3.8 minutes. The only change is that one of the versions has 4 servers, our current system, and the other has 5. You can see the servers are the little people. We can see how much of an impact this change has on customer wait time. Instead of spending 22 minutes in the system, they spend 5. Remember, 3.8 minutes of which is service time. So that means the average wait is less than 90 seconds in the case with 5 servers. Adding another server here is very efficient. Servers keep busy, and the lines were long before, so adding another server pulled a lot of people out of that line and got them service faster. So let's cue the third video. But since we're invested in since we've invested in building this decision support model, let's keep going and look at other possible change scenarios. Adding servers isn't always the only or even the best solution. So maybe someone has a clever idea, in this case, that would cut service time down to 2 minutes, say. Maybe they figured out that the menu wasn't very visible from the back of the line, and so people didn't really figure out what they wanted until they got up to order. Or maybe there was some clever idea to help them order on an iPad back in the back of the line, or just some way to make service more efficient. Okay, so let's compare the current system to this new version of the system. Here again, we're simulating 2 versions. Customer arrives about every 1 minute in both, and there are 4 servers in both. So the only difference is that the service time, okay, in our comparison scenario is now 2 minutes instead of 3.8 minutes. Without having to add another server, we managed to almost completely eliminate the wait time. So remember, the service time is 2 minutes, so time in system is just a little bit over 2 minutes in our service system with the lower service times as compared to our base case, where patients are waiting about 16 minutes. Okay, let's cue video 4 in our last video. I said before that things aren't always linear. The effect of adding a bed isn't always the same. So let's look at that, how that can be. So now we have 2 versions of the system. Okay, now we're going to consider that we make both changes. So one version of the system has, on the top, has 4 servers. The service time is 2 minutes. On the bottom, we have 5 servers and a service time of 2 minutes. Okay? So what we see here, and again, as always, one person's arriving per minute. What we see here is that adding that extra bed really doesn't do anything to the waiting time. It might reduce it 1/10 of a minute. Okay? And that's because the system is functioning differently. There aren't as many people in line to pull off. So where you are in the system, how your system's behaving matters in terms of what you get for changing the system in different ways. So that's really all there is to queuing models. We study and simulate service systems so that we can learn with them how changes in that system are going to affect outcomes that we care about. Models are the simplified versions of the world. Of course, they're approximations, but they are a great starting point. So if assumptions, if the simulated behavior doesn't match our actual system behavior, right, then that would prompt us to want to try to question the model. What assumptions that we have made are not accurate, need to be revised, so that we ultimately want to do is move towards simulating a system, a version of the system that's realistic enough to guide our decision making. Making decisions like this, using decision support models, can help us make more efficient use of limited resources. Modeling is relevant to a slew of intractable problems, for which decision making is more akin, these days, to throwing darts blindfolded. Not only can models like this aid our faulty intuition, but they offer a concrete business case for change. Models can also help stakeholders learn and come to an agreement, a common shared understanding of what better changes might look like. So, in my experience, we found modeling like this to be a very good way to get people together to reach a consensus. It's far more efficient to experiment with a simulation model than in the real world.
Thank you so much. This really made this come alive theoretically, and now we're going to move into how it's coming alive practically. Judge Leifman.
It was fascinating, and the reason I chuckled is because some of the numbers, I was doing some of the math from the numbers that Doris put up there, and it is stunning what really is going on. And also your modeling remarkably explains how we've had the outcomes that we have had, not realizing that we were in such a smart model. You know, the sad reality is that as we sit here this morning, 1 out of 104 adults in the United States are behind bars. Think about that. 1 out of 104 adults are behind bars in the United States. 1 out of 33 adults, as we sit here this morning in the United States, are under correctional supervision. Since 1980, the number of people going to jail in the United States has tripled, and sentences have increased by 166%. And as you peel back the onion, as you try to figure out why that has occurred, most of it goes to untreated mental health and substance use disorders. As Doris pointed out, you're 10 times more likely to be incarcerated than hospitalized, and you're 18 times more likely to find a bed in the criminal justice system than you are at any state civil hospital. The counties are now spending $80 billion, and Matt will get into this more because this is what drives his members really insane, because the costs are cutting into infrastructure. It's making it hard for communities to build hospitals and schools and the things that we need to survive, because so much of our money is now going into correctional costs. Now, I've been doing this for about 17 years, and I've reached a very simple conclusion, that if we treated people with primary health issues the way we treated people with mental illnesses, not only would there be a plethora of civil lawsuits, there would be criminal indictments for gross negligence. There is no other illness in this world that is permissible to send people out into homelessness in the middle of the night, and nobody bats an eye. You know, and the worst part of it is we don't give people what they need, and then we punish them because they don't behave as society expects them to behave, and we never offered them the services to begin with. And it's really a cruel, cruel joke. And what this model shows, and what we've been doing, is that yes, small changes can have huge impacts. And while this doesn't mean the system doesn't need more money, because yes, it needs a lot more money, but the reality is just putting new dollars into the existing system isn't going to change anything. The real key is making structural changes in the community that are not that expensive or that difficult to do to make the kinds of changes that you've seen up here. We did a study a few years ago with one of our really good institutions in Florida that has the capacity to tell a community who the highest utilizers of both criminal justice and mental health services are in the community. So we literally sent them the names of thousands of people in Miami-Dade who had been arrested over a long period of time that we had identified as possibly having mental health issues because of where they had been located in the jail. Now, we have huge prevalence in Miami-Dade. We have the largest percentage of people with mental illnesses of any urban area in the United States. It's about 3 times the national average. So we thought, hey, you know, we're doing this great diversion stuff. At least let's try to focus on the people who are utilizing the services the most. So we thought, well, we narrow it down to a couple thousand people, but that would be a really great start. So we sent thousands of names to this institution, and they have access to all the criminal justice records in Florida, all the involuntary hospitalization records in Florida, all the Medicaid and Medicare names. We wait, we get a list back, I open up a letter, and I'm stunned, because on this one piece of paper are the names of 97 people. Primarily men, primarily diagnosed with a schizophrenia type disorder, primarily homeless, primarily co-occurring, meaning both mental health and substance use disorders, who over a 5-year period were arrested 2,200 times. They spent 27,000 days in the Dade County Jail, 13,000 days at a crisis unit, emergency room, or psychiatric hospital, and cost taxpayers about $13.7 million, and we got absolutely nothing for it. And so when you start to model and you start to use data, what you can find is that you need to focus on the people that are killing the system, and you can get amazing results. And I'm going to come back to the competency restoration, because that is also one of the biggest parts of insanity. Well, let me touch upon it, and then I'll move forward, because we're doing something about that as well. Competency restoration sounds probably better to the public than it really is. It's an illusion, okay? And it's a constitutional requirement, which is a good thing. And when we started it, there were very few people in jails and prisons in the United States that had mental illnesses. But we're using the same system today that we used 60 years ago when there was no one in jail with mental illnesses. And so it's become a treatment system, and it's not treatment. It's a system to restore people so that they can be tried. Well, the reality is they really don't get tried. And 90,000 people waiting for competency restoration is going to cost the states, and this is what I was chuckling at, $5 billion. Now, maybe that would be okay if they were all charged with murder and they all needed to go to jail and prison, but the vast, vast, vast majority of that population are charged with nonviolent type offenses. And for about 70% of the people that have their competency restored in my state, 3 things happen to them. They either have the charges dropped because the witnesses disappear, because it's usually homeless type offenses. They get credit for the time served that they've been in the hospital, and they walk out the front door of the courthouse without any access to treatment, or they get probation and they walk out the front door of the courthouse without any access to treatment. It is the definition of insanity, where we keep doing the same thing again and again without any type of results. Very few people actually go to prison with serious mental illnesses who are incompetent to proceed. And so what happens is the states, this is an entitlement. They have no choice because this is constitutionally mandated. So what do the states do? They take the money from the community mental health system to pay for the competency restoration system, making it more difficult for people to get access to treatment, pushing more people into the criminal justice system. And it has to stop. It does not work. And it makes very little sense the way we do it. So how do you fix it? Well, we started with a mapping process in the year 2000. And I guess it's good to be judged because I can invite people to meetings who don't necessarily want to be there, and they come. And so I invited a bunch of people who didn't want to come to a meeting. They came. Look how much we're starting to save you. And we put them in a room for 2 days, and we literally mapped out on walls how our community mental health system intersected with our criminal justice system. And it did not. And we realized within moments that we were embarrassingly dysfunctional. And it's the same everywhere in the country. And everyone has these 97 that are recycling again and again and again. And we asked ourselves at one point, who's more sick? These people with real clinical illnesses that need treatment, or these policymakers, us, that have developed a system that is just designed to fail and punishes people when we don't give them what they need. And so what we realized is we needed to do 2 parts. In retrospect, it should have been 3 parts, and I'll talk about that in a minute. But we needed to stop the flow in. We needed to cut the line back a little bit. And so we looked around the country, and to us, clearly, the Memphis Crisis Intervention Team Police Program was the best. But in Memphis, they have 1 police department. I have 36. And so it was a little bit challenging. Police don't exactly like civilian non-police types like me telling them how to do their jobs. But through some grand jury reports and some really great media, our police came around. And we now have the largest trained squad of CIT officers in the United States. I have over 5,000 police officers trained. But that's only part of the story. We keep a lot of data in Miami, and we keep data on every single mental health call that my 2 largest agencies do. And so between 2010 through 2015, the 2 largest agencies handled 60,427 mental health calls, which is impressive in its own right. But what is really impressive is that of the 60,427 calls, they only made 119 arrests. Our jail audit plummeted. It went from about 7,300 to about 4,000 today, allowing us to actually close a jail. Now, when you talk about these issues, it's often misleading to talk about cost savings because it's really cost shifting. However, when you close a jail, that is a savings. When you take 100 people out of a jail, nothing changes. The staff, cost, all stay the same. But when the jail closes, there's an actual savings. And so for us, it was a $12 million savings a year. My county commission loves us. And I've been able to take a lot of those dollars and reinvest them back into new services and new capacity to keep people from recycling. But that was only part of the model. We also realized people are still going to get arrested. Some people have to get arrested that happen to have mental illnesses. And so we set up originally a post-arrest diversion program for misdemeanors. And so if you now get arrested in Miami-Dade County and you have a serious mental illness on a misdemeanor, any misdemeanor, within 3 days, once you're evaluated and you meet criteria, you are diverted out of jail. You're sent to a crisis stabilization unit. Because there is a criminal hold, the involuntary hospitalization civil law does not apply. We actually reset the case for about 2 weeks. We let the person actually get stabilized. We have a team go see the individual once they're stable, often a peer specialist. I have 7 who work for me. 4 of them are graduates of our program, and they offer treatment opportunities and alternatives for the individual. If the individual agrees to go into the program, it's totally voluntary. They are not rebooked into jail. They're taken directly from the facility to a courtroom where when they get to the courtroom, a peer specialist is waiting for them with transportation. In the meantime, we have already begun to get their benefits lined up through a program called SOAR, which expedites federal benefits. We have their housing ready for them. We have treatment ready for them. We have someone to talk to them to help them get better. Part of the problem, what we have found, is a lot of this population suffers from depression on top of their serious mental illness. These systems suck. They hurt people, they damage people, and they don't incentivize people to want to get better. So the first thing we have to do is let people know that they're welcome and warm, and we want to help them get better. And the peers help us do that. And once we break through a little bit and they want to start to get better, then they want to take treatment and we can start to work with them. The program works so well because guess what? Shocking. Recidivism went from 75% to 20% for that population. The state attorney was a hero. She was fighting crime. Our numbers were going down. But what we really were doing, we were getting people treatment. And so she allowed us to expand it to our felony cases. And so now all nonviolent felonies are also eligible for a similar program. And with the felony program, it has been amazing. 70% of the people that go into our program successfully complete it. The recidivism rate is only 6% for that population. And going back to the data you just showed, and now I know why, our jail bed days dropped by 68 years. Okay? And we're not talking a lot of people. We divert maybe 500 people a year. But those 500 people have equated to 68 years of fewer jail bed days. The jail is very happy. We are no longer under a federal mandate to reduce our jail size. We didn't have to go out and build a new jail. We're going to need one anyway over time because they're old. However, the pressure is now off and we've been able to divert some of the dollars. Well, the third thing that we did is we set up a post-arrest diversion program for competency restoration because we realized that the system made no sense. We had a major constitutional crisis in Florida in 2007. We ran out of beds. And unlike most states, we have a law that says that once you are adjudicated incompetent, the state shall, there's no may, shall take the person from jail and transfer them to a competency restoration facility. Most states have no such law, and people are languishing in jail, as was discussed. I have news for the states, if you are listening. There is a federal opinion from a real judge, and who's the chief judge of the Washington State Federal Court, who said that it is unconstitutional to keep people in jail indefinitely waiting for competency restoration. And she has said that the states have 7 days to move people from a jail to a facility. The answer, bless you, the answer is not going to go out and build new capacity. It's already, we're looking at $5 billion to restore the people we already have. That is insane. The reality is to do what we're doing in Dade. We set up a diversion program for competency restoration. It's a locked facility for people who otherwise would have gone to the facility, and instead of focusing on restoring so that they can get a plea or walk out of my courthouse without services, we changed the focus. The focus is on community reintegration because that's where they're going anyway. And then once they become stable and they're ready to reintegrate back to the community, they do not go back to the jail, they go back to the courtroom, and they get put into our diversion program. Almost zero recidivism in 5 years, okay? It's about a third cheaper, it's a third quicker, and people are getting the services that they need. So the key is to change the way we think about these things, because the way we're doing it now doesn't work. And these are small changes. These are not very expensive changes. Where the expense begins is in capacity building. I'm lucky in Miami. I have certain capacities that other communities may not have. And that's where you have to take the dollars you save and reshift them into capacity so people can get these level of services. How do we scale this? Matt's going to talk more about this, but I would be remiss not to mention a national initiative that we have begun with the American Psychiatric Association Foundation, who's represented here today, the National Association of Counties, and the Council of State Governments, along with the Justice Department, NAMI, Sheriff's Associations, and others, who are really figuring out how do we scale these changes. It's called Stepping Up. It is a wonderful initiative. We need help, but little changes in the community can lead to massive cost savings and, more importantly, helping people who are just sick get into recovery, have hope, and get their lives back. Thank you.
Thank you. Matt?
Well, good morning. Toughest job is to always follow Judge Leifman. So, I do want to start by thanking AEI and the Treatment Advocacy Center. This issue at the county level is at the top. It's a nonpartisan issue, a bipartisan or tripartisan issue, and there is incredible leadership and passion at the local level. It doesn't matter how our elected officials come at it, whether it's through being a fiscal conservative or wanting just to focus on public safety or being a mental health advocate, they all align at the grassroots level because people are experiencing this through their families, through their neighborhoods, and through their communities. My personal background is my mother was a mental health nurse. Growing up, she worked in the MHU, and my stepfather who raised me was a district attorney and a judge. And so I grew up around this and didn't quite fully appreciate it till I was in this job. But reflecting back, I can see why it's so important to our communities. I want to set some context to really understand the county role and not to deflect responsibility at all, but I want to explain some federal policy, state fiscal pressures, and local context of how counties operate. The first thing to understand is county governments across the country, our total budgets, if we were a business, would be $560 billion a year. Nobody knows that, but $560 billion a year, we have 3.6 million employees. So the scale is huge. Almost more than 1% of Americans work for county government. Most folks think of cities and mayors, and typically they get the credit for the work that we pay for and do. And so when you look at the role in healthcare and human services, it's huge. Counties spend about $84 billion a year on healthcare for citizens. And we spend about $20 billion for our own employees. So 1 out of every $5 we spend is typically on healthcare. In most states, we have responsibility for indigent care. So if you're uninsured, if you're poor, you show up at an ER, we're typically paying. We also have 26 states that have to pay a portion of Medicaid with the state. So if you're in New York State and you're a county, the county send the state government $144 million a week to pay for the state share of Medicaid. If you're in Los Angeles County, you're spending about $5 billion a year on Medicaid. We also own 1,000 hospitals, 600 nursing homes, and have public health, behavioral health in a lot of states. In the justice system, there's a lot of focus on the federal and state prison system, which has 2 to 2.5 million inmates who obviously stay longer. County jails admit about 12 million individuals a year. 12 million individuals a year. Really about 8.5 million individuals with 12 million admissions. The scale is huge. Our largest county, Los Angeles County, with 10 million people, 88 cities. The city of LA is only half the population of LA County. LA County would be the 7th largest state in the union, the same size as Ohio or Michigan. To put it into context, they have 16,000 inmates in their jail every day. So if you've ever been to a Washington Wizards game or a Washington Capitals game, think of that entire arena filled would be the size of their jail population every day. So the scale is enormous. The county is looking at replacing their central jail. It will cost about $2.5 to $3 billion to replace that jail. I joke, that's HUD's Community Development Block Grant Program for community development across the country. That's their total budget for one jail. Because they're not building a jail, they're building a hospital with a jail around it, as the judge talked about. So the county role is unique in that we're the middleman. So city police typically are the ones that do the arresting. In very few jurisdictions do the police or the city pay for the jail, pay for the district attorneys, pay for the public defenders, pay for the judges, the courthouses, and the health care for those inmates. That is on the county. So we're at AEI, and you can't talk about markets and incentives. You have to talk about that when you're at AEI. The problems with incentives are they work. So if you're in Chicago, Cook County, the mayor can arrest people all he wants with the crime problems. He's paying for the officers. The county pays the rest of the cost. They have to pay for the public defenders, the district attorneys, most of the judges, certainly the buildings, the facilities, and healthcare is a huge cost within the jail. The other thing to remember at the county level is most of the actors are independently elected. The district attorneys are elected. The judges are typically elected. The public defender's elected. In most cases, even the coroner is elected, unless they're a medical officer. And so, again, going back to incentives, going back to my father being a district attorney and a judge, that's a risky proposition to let people out of jail who have mental illness, who may be perceived as violent, even though they're typically not. That's a political risk. They all remember Willie Horton in the Dukakis-Bush election. So we're in a tough spot. The other thing is the sheriffs are elected. Police chiefs are appointed by the mayor and a board. The sheriffs are independently elected, and they run the jails. So the members that we work for are typically the appropriators, the bankers, the county commissioners that appropriate the money. And so that's why we have things like the Stepping Up campaign, which are really focused on reducing the number of folks in our jails with mental illness. In fact, trying to avoid sending them to jail and to divert them into proper facilities and treatment, to connect them to the appropriate community services, and to ultimately make them productive citizens and have healthy lives. And so we're spending a lot of time bringing independently elected actors together with the nonprofits. Private sector is also very engaged in this. And to really look at what is the prevalence of this issue in your area. Don't put your head in the sand. Acknowledge it as a serious issue. Really look at what are your capabilities and assets. One thing to remember about this country is we have 3,000 plus counties. 50% of American people live in 144 counties. So the other 50% live in 2,900 counties, as we all saw in this election. But a lot of those rural areas don't have the hospitals, they don't have the psychiatrists, they don't have the mental health professionals. And so how do we look at what are your capabilities and your assets? Develop a plan, look at data-driven, evidence-based practices, and really focus. And so we're proud that 320 counties, almost 40% of the US population being covered, has voluntarily, the counties have adopted resolutions saying this is a significant issue. We are going to focus on solutions for the future, and we want to move ahead. One of the things that hasn't been talked about is during the recession, state governments cut $4 billion in public mental health funding. Not only are they closing the hospitals and the beds, which may be a good thing, going back to institutionalizing these folks and putting them into a community setting, but what's happening is there's massive budget cuts of over $4 billion at the state level. States were responsible for this population. This is a state's issue. The counties have just been left with it because the jails were the alternative. So when folks write papers making it look like the counties were the cause of this, no, we're the recipient. Now we're going to own it, and we're going to look at solutions here. There's also policy issues. So if you are a veteran and you have veterans benefits and you are arrested, you lose your VA benefits, not convicted. Your VA benefits are suspended or terminated while you are in jail awaiting trial, not convicted, remember. The same thing with Medicaid. As soon as you are arrested, your benefits are either terminated or suspended. We think, as long as you're in the pretrial status, you should continue to receive your Medicaid and your veterans benefits, because that allows us to do the continuum of care. A lot of these folks with mental illness are going off their medication. They will be treated in the jail, but those 30 to 90 days where they're waiting to get back on Medicare or Medicaid, depending on your state, they're typically not being treated. So there's a lot of policy issues that we want to deal with. And then, of course, there's this new explosion that we were talking about in Massachusetts and others with the opioid heroin crisis and the substance abuse crisis, often being interwoven with those with mental illness. And so it's a really complicated time. But the good news is the elected officials are really tackling this, whether the judges and the prosecutors or the county commissioners. We can't run from it because we can't afford to continue to subsidize, if you will, this problem. And so what we're looking for is to improve community safety. Public safety is always the top goal, but also treat these folks humanely and put them into settings where they can thrive and recover. So with that, I really want to thank AEI and the Treatment Advocacy Center for raising this issue beyond our inner circle that we work on this every day, and we really appreciate it. And I'll just close with market incentives work. And so if we can align the incentives for better outcomes, as the judge has done in Miami, we will move the needle, and we are. There's a lot of great counties, whether it's Bexar County, which is San Antonio. Everybody calls it Bexar. It's Bear, trust me. Or King County. You're seeing New York City, Los Angeles. Sometimes it's court-ordered, and sometimes it's just folks doing the right thing. So we're optimistic about the future. And it's not all about money. It's really about collaboration and getting folks going in the same direction. So thank you.
Thank you. Mike?
So thanks everyone for showing up today. I think it falls on me to put some flesh and blood on the issue here. And so I'm going to tell you a story about one of the new asylums. And I think what I have to say may shock you and alarm you, and in a way I hope it does, because I want you to feel that this is really an important problem that has to be solved. But first, I want to tell you the good news in Massachusetts is that last month, Governor Charlie Baker used his State of the State address to ask the legislature for $37 million in new spending for a forensic facility that is known as Bridgewater State Hospital. And if the governor's proposal is adopted, all the prison guards who now run the facility will be moved out and replaced by private security officers who are trained to handle men who are mentally ill and sometimes violent. The number of psychiatrists and other mental health clinicians will go up. And perhaps most importantly, the routine and illegal use of something called 4-point restraints and solitary confinement will be sharply reduced and perhaps even eliminated. But this rare piece of good news has come at great cost to the 300 men who have been held in this facility and to their families. Over the last few years, 3 men have died at Bridgewater needlessly because of the use of 4-point restraints. 4-point restraints is the practice of strapping a patient down by the wrists and ankles, and it's a practice that has been thoroughly discredited by mental health care professionals all over the country because it is both cruel and dangerous. But despite really a nationwide movement to eradicate this tactic, there are scores and perhaps hundreds of men at Bridgewater who have been routinely tortured through the use of 4-point restraints and solitary confinement in a section of this facility known as the Intensive Treatment Unit. Treatment. It's doublespeak, and it's not unusual at Bridgewater. In fact, Bridgewater is not a hospital at all. It's not accredited as a hospital. It's not licensed as a hospital. In fact, it's a medium security prison run by the Department of Correction. And it's one of only 2 forensic facilities in the country that is run by a Department of Correction instead of a Department of Mental Health. This would be readily apparent to any of you if you ever visit Bridgewater. You'll see that it's surrounded by a high chain link fence and coils of razor wire. And if you venture inside, you would find that the troubled men who live there, despite the presence of mental health care clinicians, are treated as prisoners and not as mental health patients. The road that led to Governor Baker's very welcome reform proposal began more than 3 years ago. And that's when I learned that a young man suffering from paranoid schizophrenia had been killed as a half a dozen guards brutalized him while wrestling him into 4-point restraints. Joshua Messier was 23 years old at the time of his death. He came from a middle-class family. He was a freshman at the University of Massachusetts when he was afflicted by his disease, and he had never been convicted of a crime. So how, you might ask, did Joshua come to reside in a medium security prison where untrained prison guards would take his life? First thing you have to understand is that both the private and public medical insurers in this country do not reimburse hospitals for the full cost of keeping someone in a psychiatric bed. In Massachusetts, the reimbursement rate is about 60%. And this, needless to say, is a pretty good incentive for hospitals to deliver inadequate short-term care and to engage in what a lot of people are calling patient dumping. And that's what happened to Joshua. As someone suffering from paranoid schizophrenia, Joshua was not only expensive, he was also difficult to manage. So when he punched an orderly while being held in a private hospital in a psychiatric ward, the hospital was eager to get rid of him, and they had the orderly file misdemeanor assault and battery charges. So the judge hearing the case could see that Joshua was heavily sedated and ordered him to be moved to Bridgewater State Hospital for a psychiatric evaluation to determine if he was competent to stand trial. And once at Bridgewater, Joshua died within a month. So how did he die so quickly? Well, due to his illness, Joshua allegedly punched a guard, same thing that happened in the hospital. And I think if you talk to any experienced psychiatrist who has treated men suffering from paranoid schizophrenia, they will tell you that getting hit every once in a while goes with the territory. But in a prison setting, usually what happens is the guards retaliate. Joshua's autopsy shows that he was severely beaten. It also says that he was killed when guards dragged him to the intensive treatment unit and started placing him in 4-point restraints. And I'll tell you what happened. Even though Joshua was calm at the time, his psychotic attack had passed to the point where he was actually apologizing to the guards. They sat him on a small bed, and his hands were cuffed behind him, and they jumped on his back and folded him in half so that his chest was touching his knees. And in this position, surprise, surprise, he couldn't breathe. And very quickly, his heart stopped beating. So how do I know all this? Well, I know it because, believe it or not, all of this was captured on prison video. And the prison video shows Joshua's face turning blue as the guards continue to strip his clothing off of him and secure his wrists and ankles down to a small bed. I also know it because the state medical examiner said that Joshua died as a result of the actions taken by the guards and ruled his death a homicide. But incredibly, after Joshua's death, nothing was done. None of the guards were charged, prosecuted, or even disciplined. Instead, the department covered up the circumstances surrounding his death. And just to cite a few examples, there was an internal affairs investigation faulting the guards that was simply overruled by a deputy commissioner. And there was a use of force report also faulting the guards that was literally stashed in a desk drawer by the commissioner himself. And a medical peer review of Joshua's death, which is required by Department of Regulations, simply never happened. After I revealed the cover-up, the governor at the time, Deval Patrick, formally reprimanded the commissioner, fired the deputy commissioner, and suspended 3 of the guards who were in Joshua's cell the night he died. I'm sure at this point, Governor Patrick hoped that the story would go away. But at that point, I had a lot of questions about Bridgewater State Hospital. So I kept digging, and I discovered that 2 other young men had died at Bridgewater due to the use of 4-point restraints. And digging still further, I found that the guards at Bridgewater were using 4-point restraints and solitary confinement at a rate more than 100 times officials at other state mental health facilities. I also found that they were using these tactics at a rate many times greater than officials at similar facilities in other parts of the country. And in addition, I challenged the district attorney's decision to ignore a homicide without ever presenting the case to a grand jury. Eventually, civil lawsuits were filed, and the medical records that were turned over in the discovery process showed that 4-point restraints and solitary confinement were being used on a routine, daily basis to the point where some men were held in solitary for months at a time. Eventually, Governor Patrick fired the commissioner and the guards, and the state attorney general named a special prosecutor to investigate Joshua's death. As a result, a state grand jury charged the guards with manslaughter and criminal civil rights violations, and the guards are scheduled to stand trial later this year. As you might imagine, the indictments have delivered a measure of justice to Joshua's mother and his father and his younger brother and sister. But Joshua's family, I think, is especially heartened by Governor Baker's reform proposal because if implemented, it would mean that Joshua did not die in vain. All that said, I want to tell you that Bridgewater is just a small piece of the mental health care system in Massachusetts. And in a separate series of stories that I wrote with my colleagues on the Boston Globe Spotlight team, we showed that the shortage of psychiatric beds represents not only a tragedy for the people suffering from mental illness and their families, but is also a public safety crisis. Over the course of a year and some very tedious research, we found that more than 10% of all homicides in Massachusetts are committed by someone with a serious, usually untreated mental illness. And very often, the victims are the very people who tried the hardest to get treatment for their loved ones, talking about fathers and mothers and other family members. In the course of our research, we also found that the victims of nearly half of all fatal police shootings are people who are either suicidal or were suffering from a mental illness. Most of these police officers had no training whatsoever in handling confrontations with people with a serious mental illness. Today, there is a movement, and the judge mentioned it, crisis intervention teams to provide police with that training, and I think that's great. But I also think that a better idea might be to build a better mental health care system so that the police can do the jobs that they are trained to do. In our reporting, my colleagues and I on the Spotlight team, we also documented what you've heard described here today, which is the revolving door of people with a mental illness passing through the court system, the prisons, who are then released only to commit new crimes and land in prison again. But we also came to understand, especially while investigating the homicides, every single homicide in Massachusetts over a period of 11 years, that the mental health crisis in our country is not only a tragedy for low-income, forgotten Americans, although it is often that, it is also a frightening and dangerous reality for middle-class citizens who are desperate to find treatment for loved ones who are suffering from a mental illness and through no fault of their own may sometimes become dangerously violent. So it's really become a problem for everyone, touches almost everyone. So I applaud all the solutions that have been put on the table here today. I hope they're implemented and I hope they work.
Thank you. And now actually for a few more solutions. Back to Doris to talk about the policy recommendations in the report, and then we'll go to questions from all of you.
Yeah, we didn't want to just describe the problem and describe the model. We have some recommendations to move things forward because this is a situation that desperately needs addressing. And I really appreciate, Mike, you bringing up some of even the larger issues. We're just looking at one small part of it in this study, which is our pretrial detainees, our defendants, never been tried, who are too sick to go to trial. So we have recommendations for at both the state and the federal level, and I'd love to hear Matt maybe address some of the changes that can happen at the county level. You know, at the state level, wouldn't it be wonderful if everybody would, every state would invest in and put to work mathematical models like this? This is, we can see that we can model solutions that will require small changes, not big investments, and make huge differences. So we need to see the states embrace this, implement it, begin to use evidence-based tools to come up with evidence-based solutions to this problem. We need to expand diversion programs. I mean, Steve is like the poster child for, you know, better diversion. You don't need as many jails. You don't have as many people sitting in jails. You don't have a lot of other problems. You save money that you can use elsewhere and get better outcomes. We want better outcomes. So we would like to see investments in mathematically based planning tools for state governments to use. Counties could probably use them too. Reduce forensic bed demand. before and after arrest by expanding the use of diversion. And this includes CIT, it includes ACT teams, it includes FACT teams, it includes AOT. There are so many diversion tools we have that aren't being used as adequately as they could. And as Kristen's video showed, if we could just cut the number of people reaching the jails, it would cut these waits, it would reduce, even close some of the new asylums. We need to have states take a look at their discharge policies at their state hospitals, at their length of stay, at some of their administrative and bureaucratic obstacles to managing their bed capacity better. And you know, at the end of the day, we need beds. I mean, all of these, and we need beds because 1,800 beds for all of these people is just not enough. I'd love to have Kristen crunch those numbers. We know it's not enough, but the thing is we don't need a massive building program necessarily. We have an untold number of psychiatric beds in this country that are built and sitting in a hospital somewhere, and they are empty. Why are they empty? Because they're not staffed. Why aren't they staffed? Well, because we've had these budget cuts, because we have terrible problems that the 21st Century Cures Act is trying to address with professionals to staff these things. I mean, Matt's comment that we don't have a mental health professional in half the counties of America. We need to do something about that. So if we could staff beds, we could just turn existing beds into useful beds, operational beds. So those are some of our state recommendations. At the federal level, we need to get the appropriations from Congress to fund the provision in the Cures Act that will expand criminal diversion, the criminal justice diversion of people with mental illness. Those are in the act. We need to get those put to work. Let's put to work the things we know that work. There are provisions in the Cures Act to grow the mental health workforce. We need a bigger mental health workforce, not just to staff beds, but to staff the community services that help prevent people from getting and needing beds. We need to repeal the IMD exclusion. You know, it's federally sanctioned. The IMD exclusion, for those of you who, several heads nodding, you know, if you haven't encountered it before, it's a policy that excludes reimbursement. It excludes institutes of mental disease. That would be facilities that have more than 16 beds, of which more than half are committed to treating people with mental illness, psychiatric disease. So that's state hospitals, that's all sorts of other private hospitals that are psychiatric, you know, dealing with psychiatric patients. They can't collect Medicaid for those patients. So if they were a facility for someone with heart disease or cancer or any number of other things, anything under the sun except mental illness, if you're an adult and you're in one of those facilities, Medicaid will not pay for your care, which is, talk about incentives, a great incentive not to have beds for folks with mental illness. And then let's get some funding for more jail diversion programs, the pre-arrest jail diversion programs like they're running in Miami-Dade, and the post-arrest. The crisis stabilization. Instead of people, you know, people that are at risk for in other places would be taken by police to a jail cell and booked and become one of those 90,000 people, they are taken to a crisis stabilization unit. And you know, that's not just about they're not in a non-therapeutic jail. It also means they're not getting that arrest on their records. That means they're not running into obstacles to housing and jobs. Exactly. I mean, there's so many secondary impacts of being arrested when you're mentally ill. So let's get some funding for that. And you know, at the end of the day, we need to be doing a better job at looking at net costs. What all of us, I think, have touched on here is we tend to just take this siloed approach, especially to superutilizers, but to mental health care in general. We don't look at, oh, if we treated people more effectively in the community, how would that reduce the budget that we need for those county jails? We need to do a better job of looking at the bottom line for human beings, but also economically, because I think that that's another place we'd find those small changes would make big differences.
Matt, did you want to add?
I was going to add, well,
Great.
thank you to Michael for raising some of these issues. It reminds me of Judge Leifman, who several years ago exposed the forgotten floor in Miami and brought in a TV crew to expose the jail. As a judge, that's incredibly courageous. And
We're dumb.
we're dumb. You're still here. In Miami, that's quite a feat. But the advocates in these tragedies have really raised the awareness. And the state of Kansas, the governor is proposing some massive cuts to their state public health or mental health. And where the state legislator said it best when it says it costs us a ton of money to be cheap. And I think that's what you're saying is we're actually spending the money. But in the Massachusetts case, they're spending a lot in lawsuits and payouts to these families that money could be put into treatment and doing the right thing.
Yeah.
And so there are all these cases, and there's some really bad ones across the country, but overwhelmingly, there's a movement to fix it. And so your research that the Treatment Advocacy Center is bringing forward, we're seeing a ton of focus on data, breaking down these silos. It's really tough on the data front because the police have their own computer system, the jails have their own computer system, and the courts have their own computer system. And getting those through, people claim HIPAA, but we know we can actually work through HIPAA. And Miami is a place that has successfully worked on this. We just see a lot of opportunity.
Great, thank you. Okay, now we are taking questions. I'll let that gentleman.
Hi, my name is Carl Pulzer, and I'm a longtime health policy analyst, but I'm here today, so I go to other meetings here. I've gotten involved in mental health because I'm a caregiver with my wife for a young adult with serious mental illness that recently had a hospitalization in Arlington, Virginia. And we, as a result, I've gotten involved with a citizens group, and others are here. The Arlington Mental Health Alliance, we're asking the Virginia Hospital for more beds. And yesterday there was a conversation where we could have used some data. Virginia is one of the half of the states that has a certificate of need requirement. So the kind gentleman came from there and talked to the citizens. He said, well, this hospital has 75% occupancy for mental health beds. But our experience in the county, there's a county agency called the Community Service Board, said, well, we have 200 people or 400 or 600, or something in the hundreds, that were denied access last year. So I said, that's a conflict of data. So it turns out there are two possible suspects. One is, do you use beds or days or rooms? Because you can have, I told the guy, well, what if you have, they have 20 beds, say. 10 have double occupancy and 10 have single occupancy because the person from the forensic system can't be with somebody. You have 75% occupancy, but you have no available rooms. So both of these statistics could be true from these different perspectives. And that's an issue. So how do you count? The second issue is the second largest health plan. Now the planning is done on a county basis in our Northern Virginia, but the health economy is a regional economy. And the second largest insurance carrier, Kaiser, just signed a long-term agreement with this hospital to take 70% of their patients. And they're drawing from, Arlington's only a fraction of the whole Northern Virginia area. So they're being funneled in there at an increasing rate. And I think the state that, the state certificate of need people control the valve to this access. And he was very, very reasonably understanding what we were talking about. The data they have is just too crude. And in your model, you need to account for, I just wanted to throw that on the table. I know it's a little wonky. But.
No.
It's a real life example.
Yeah.
Many of us in the audience agree and have faced these shortages at Virginia Hospital Center, and we do need data. We appreciate Doris Fuller's help in presenting data on that.
Can I react real quick
please.
to that? So one thing that I want to say, in working with the data that you did collect, one thing that we found with the models is that we could sort of test the internal consistency of the data. So sometimes we would get information about sort of demand, and we'd get information about capacity, how many staff beds are there, and average service time. And there's no way we could show with the model. There's no way those are aligned, right? And so that is a good way to sort of take the pieces of data that we get, the snapshots, at least our sort of understanding what people are telling us is going on, run it through the model, get a sense of what the implications might be for, there must be something different. So you can push back on the assumptions. So sometimes we can use the data we have and a model like this to try to push back and say, all right, something's wrong, it's either this or this, which one do you think is right? But to get to your point about, we tried to make our model as general as possible at this point because it seemed like a reasonable starting point. So we're working with beds, but I think your point's a good one. We need to understand that service system very carefully because it has ramifications for everything you said, utilization, waiting, flow, and we should be looking at opportunities to increase efficiency by changing that up.
Sir?
Hi, Pat Span, just represent myself. I almost remember when your slide there with the 550,000 beds in the mid-50s, and I remember when the movement to close those institutions, and I mean what's happened now is not exactly unintended consequence, it's quite predictable if you stop and think about it. And matter of fact, if we had those 550,000 beds, that's double what you were saying was in the prisons. And so when the people shut down those beds, and I know the federal government, the state government, the movement to get the people out of the institutions, what were they thinking? Or what was, I know there was some talk that, oh, we're going to move them into community group homes, which obviously never happened. And I guess could the panel sort of address why we are the way we are when we had the institutions back in the 50s?
So it's a classic cost shift. So again, states were responsible for it. The judge can talk about a great example where he is rehabbing an old state psychiatric hospital that the county, you tell the story, but it was a state-run facility that was closed, mothballed, and now the county has bought it from the state, putting
42 now.
42 million. You tell the story. But it's just one example of one level of government shifting it to another, and it's not that easy, but it's a classic case of states not investing. We're at the bottom of the heap with the jails, and it is predictable.
Yeah, it was predicted at the time. There was a study by a guy named Abramson called The Criminalization of Mental Illness and predicted exactly what was going to happen. But it wasn't irrational. In the 50s, many of these state hospitals were hellholes. They were houses of horror. They were experimenting on people without any basis, and they were torturing them. The promise that wasn't kept was that the Congress passed a Community Mental Health Act under President Kennedy that authorized up to $3 billion in services. It's even a lot today. And sadly, due to his assassination and the escalation of the Vietnam War, not one penny of the $3 billion got appropriated. And so at the same time, federal cases came out because of the horrible conditions in these facilities, and the states were ordered to either clean them up or close them down, and they chose to close them down. In fact, one of the most interesting statistics is we put up on the board that there were about 1.8 million arrests last year of people with mental illnesses. Well, if we had never closed the hospitals, and I don't advocate that because they were horrible, if we had never closed them and the population in the United States continued to grow as it did, there would be almost exactly as many people in hospitals as were arrested last year. It's almost 1 for 1. Okay, so the problem was, and this is what we have to go back and start to do, is we have to start to improve the community mental health system. And we have to begin to divert this population to the appropriate services. And Matt touched upon it earlier. It's really about developing these collaborations with all the different diverse stakeholders to get them to do something different. And that is not expensive. It just takes some leadership, a little bit of political will, and getting people to understand, either using these models or other examples around the country, that it can be done and you can actually improve public safety. I always chuckle when I hear, they're worried about public safety. Well, putting someone in jail with mental illness for even a few days and then releasing them, which everyone gets released, is not an improvement of public safety. You're making people worse. If you want to really improve public safety, improve your mental health system, and people aren't going to end up in the system to begin with. Jail doesn't do much to really, unless they're indefinitely, which they're not going to be, nor should they be, doesn't do much except make people worse. Most of them have serious trauma issues, And jail re-traumatizes people, and it actually makes their conditions much worse than when they went in.
And
So,
there's,
and I'll just point out real quick, counties are changing their behavior, including with our nonprofit partners. I was just in Leon County, Florida, which is Tallahassee, and they built this beautiful new, what you would call a homeless shelter, they call it a wellness center. And they now have a partnership with the jail that when they know folks who are either homeless or have serious problems, they actually have the nonprofits meet them at 12:01 a.m. and they aren't discharged to the streets, they're actually discharged to nonprofit communities who then deal with whether it's mental health, substance abuse, maybe it's a workforce issue, a lot of times it's domestic violence. But just even a year ago, they would have been just pushed off into the street.
A warm handoff is not expensive.
Right.
People are already doing this service. You just have to line them up the right place at the right time, and it makes a world of difference.
I just want to add one more historical footnote, which is that at the time the community centers were supposed to open up to these folks, the prevailing ideology of treatment wasn't really geared for people with the most severe illnesses. There was almost a sense that the environment was one of the major agents of pathology. So a lot of these community mental health centers, which did crop up, were focused on almost social justice issues, which are important, but that's not going to help you when you have schizophrenia. And that's actually one of the biggest points now about I have some hope for, frankly, this administration, because for that orientation has actually been filtered down through the years so that some of our federal agencies still, in my view, and I know it's shared by others, put a disproportionate emphasis on people who need help, to be sure, but are not the sickest of the population.
Right. And the problem is a one shoe fits all, which is what we use, does not work. These are mental illnesses. They are different, with different pathologies and different degrees, depending on how long people have been sick. And so one of the things that we're working on now that Matt touched upon is we are opening a one-stop shop for the most acutely ill in Miami-Dade County. It's the old Forensic Competency Restoration Facility. It's 180,000 square feet. The state leased it to us for $1 a year. The taxpayers in Dade County passed a bond issue for $22 million, and the mayor just gave us an additional $20. And it'll have a central receiving facility for the police to drop off, or if you get arrested. And it'll have a crisis unit. It'll have a short-term residential facility. It'll have a day activity program run by people with mental illnesses. It'll have a supportive employment culinary program. It'll have a primary health unit, because the other thing we are not talking about, which is the other major cost drivers, is most of this population, particularly homeless, has major primary health care issues that are not getting addressed. So we will put a primary health clinic in there to address both primary and psychiatric. We will have a courtroom, hearing room that we can process cases. We will have trauma services and all the other supports that people need for recovery. And it's going to be for those 97 I talked about, that the system is not, even to this day, geared to handling those most acutely ill. And instead of just kicking them to the curb once we adjudicate the case, we will slowly reintegrate them with all the services that they need for recovery and to stay in recovery. And that's the key. It's not locking everybody up. It's not institutionalized everybody. It's assessing what people actually need, just like any other illness, and then giving them and delivering those services. And it's more cost efficient if you target the population.
Dr. Picard?
Thank you, Sally. First of all, well, terrific. I know you're surprised to see me. I've never been to the AEI before. I think I set off a buzzer when I walked in. I'm not sure what that is for. I spent 25 years in the intramural NIMH, where I ran the schizophrenia research program in Bethesda. And in my old age, drug development. But what I do now as an old man is live this every day with real people in real time and do the best I can. And it is a very tough thing to do. Treatment advocacy, heroes. Fuller Torrey was my first hero in psychiatry, and I go way back. Rubinow, do you know Rubinow at UNC, head of psychiatry? He's one of my guys. He's my crew, right? And you guys are just famous. So that's the introduction part. Should I say it, Sally, or behave?
Go for it.
Okay, one, the reason that people got out of the state mental hospital closed was because of antipsychotic drugs. You're completely missing it.
Well, that's
100%.
Thorazine.
Not, wait a minute, not 10%, not 50%, 100%. These were the first miracle drugs of psychiatry and of medicine. And if you don't think they work, there's no place anymore, since our unit really has been closed, where you can see a drug-free schizophrenic and see how sick they are. Two, it is not like every other illness. These are not like every other illnesses, okay? What illness where the core of the illness is to deny that you're sick? You got another one? I got diabetes. I deny it. Okay, so I don't. All right? But that's the illness here. And those 97 folks, I promise you, do not believe, I'm guessing that one, do not believe they're ill. So what I say to you guys is get a little closer to the illness. There's been a very bad thing. Now, my guys in the research world, my old guys, I'm sort of cross-dressing these days, don't know about you. I'm getting Tim Landry to come to Mass General, Tim Murphy, excuse me, to tell about his bill. They are clueless, the academic community, about what you're trying to do. And you're a little bit clueless about what they're about and what the illnesses are. You've got to get closer. And you talk about beds. Okay, I just had, I emailed one of my, texted, I think is the words the kids use today, one of my old-time guys. I ran the research ward at the clinical center. We had about 10 beds for schizophrenia. My charge was to take it out of the psychoanalytic world and make it modern, and proud of those years that happened. And Fuller was more of a inspiration in his own unique way. Dr. Torrey was in his own unique way. So we had about 10 beds there in the clinical center. At St. E's, there were 50 research beds for schizophrenia at the exact same time. That's how I know Fuller. I was preppy and in the clinical center. But if you wanted to be on the front lines in the day, you were at St. E's fighting the battles. Now, do you know how many research beds are at St. E's now? Mike, do you know how many?
I don't.
0. That means bupkis.
I'm not
Nothing.
surprised, yeah.
Closed. Over. And that's been for years. How many of my old beds? They're barely filled. So where am I going with this? The research community is drifted away from our patients. It's a terrible thing that's going. We all know about it. Everybody knows about it. That's just one concrete example. And Mike, you should take a look into that as well. So while you folks are doing that, which is so right on, it's so important, connect back to people taking care of patients.
So just so you know, through the American Psychiatric Association Foundation, which I sit, we created something called the Judges Leadership Initiative Psychiatric Leadership Group. And we have psychiatrists and judges meeting to better inform each other on what we're doing and to learn more about the illnesses and how to treat the illnesses. And we're scaling it, or at least we're attempting to, because you're absolutely right. There is a huge void about what we've known, and we developed a validated training program for judges around the country through this. Using a psychiatrist, we go out in teams to the states, and we're now training judges on how to recognize people with mental illnesses, how not to escalate a situation in court, but more importantly, how to serve in the community to develop these kinds of programs and diversions and to get people the services and the treatments they need.
The notion of freeing people from mental hospitals without any concept of the seriousness of the danger to families, to others. This is something we've battled for as long as I've been in the business. And I don't know that it's particularly better now. You guys know better than I do. But it is a serious problem. And facing it front on, many of these folks are dangerous. Doesn't mean that they should be in jail necessarily. But you can't medicate them against their will. In Maryland, you know, you can send somebody against their will to a hospital, but you can't force medicate them. You know that? Oh, that's helpful. So it's it doesn't feel to the clinical person that system's on our side. But what you guys are doing is enormously important. And reach out, tell Dr. Torrey to reach out more to the research community and to the academic community or the treatment community. And the APA is the APA, but I'm talking the real thing.
No, we need to be reaching out, for example, to family practitioners because they're prescribing half of the psychotropic meds in America. So we need to be reaching out to the medical community in general. But another part of that is if we look out at some of the diseases where we've made great progress in America in the last 20 years, AIDS, for example, some of the cancers, you have the research community teaming up with the advocacy community and coming together to say, we're all in this for the same reason and working together. And that has really not happened with mental health research and the mental health advocacy community. And it's something at the Treatment Advocacy Center that we have started working on in some ways because ultimately we're more powerful in getting what needs to be done if we do embrace the research community as well as the advocacy and the treatment community.
Oh, this lady? I thought you had a question, but yes, ma'am.
Thank you all. I'm Linda Stalters with Schizophrenia and Related Disorders Alliance of America, and I'm very familiar with what you're talking about and how critical everything that you're talking about is, and it brings tears to my eyes because
of all the people that I know, the people that we talk to, and the struggles and the pain that people who, their families, and the people who live with these brain disorders. And I'm so glad to hear you say illnesses and disease, because these are illnesses and diseases, and we need people to understand that. These are not things that people elect to have.
It's not
And
choice.
It's not a choice, and I think we need to change how we speak about these things so that people understand. And I used to practice around here, and I would try to refer people for research, and we do in our organization, help people to understand that research is available, but also, give them some education about that, because it is a way to help them get into treatment as well. And we do have to practice together. We all need to work together. And the cruelest thing is not to treat people. The cruelest thing, we don't do that with other people who have other illnesses. Alzheimer patients can become very combative and hurt one another and other people and providers, but we don't treat them the same.
Thank you very much. I need questions, though. Do you have a question? Okay, that lady over there. And we'll take one more after you.
Hi. So my name is Kana Chuk, and I am a student at Georgetown University. I'm supposed to be in class right now, but it's okay. Anyway, first I want to thank you all, panelists, and everyone here for coming and caring about mental health. So I grew up in a community, Oakland, California, actually, where mental health isn't talked about and treated, as it is a lower income community, and also we have like really, really high crime rates and jail rates. So this is actually an issue that's very personal to me. So I just want to ask, how are ways that we as citizens can get involved in this to make all these changes that you guys talked about today?
Thank you.
Well, I would say you're in Alameda County, which the County Board of Supervisors, their CEO that runs the county day to day, are very engaged in our initiative. And so we can help connect you. They have a very open door. As you said, in your county, it's really two different counties, the wealthy side and the side that's struggling with a lot of these issues. And so we can connect you. And they are looking for citizens to get engaged.
Thank you. And just make your question quick, and then we'll.
I'm going to stand up. It's actually not a question.
I want a question.
I do
We
have
really
a question
need questions, though.
I am actually an advocate, and I am a mother of a mentally ill inmate. My son was arrested, went to jail, prison for 4 years, put on probation for 5 years, and he was released from prison. Unfortunately, at the time he was released, which was September 2015, I'm not going to be before you long, I had a tumor in the back of my brain that was removed. And unfortunately, he didn't have a place to live when he came home. So they paired him up with another group of people, and he relapsed. My son's biggest problem is he becomes non-compliant. He's a big guy, he's 6'3", and he's big, so he's a threat. And also, when they give him Haldol, it has an adverse reaction on him, which makes him become assaultive. I mean, just hitting people. And by him being a big guy, and he's make a long story short, my son is back in jail. He was having problems, and I kept trying to get him, taking places, like this man was saying, taking him to all these different hospitals. They keep him for 7 days, release him, unstable. Finally, we got him into a place, and they were trying to get him stable. He became aggressive. They shot him up with Haldol and began to hit him. So what did they do? They called the Bucks County Jail. Bucks County Jail come and pick him up, bring him back to the mental health unit. You know what that date was? May 27, and I get very emotional. 2016. My son is still sitting in solitary confinement at the Bucks County Jail. I call up there every day. They know me. I go to see him. They were allowing me to visit him once a week for 30 minutes. My son is deteriorating, going down the drain. So he finally had a misconduct. He didn't hit anybody, but he had a misconduct. He couldn't go along. You don't want to hear, please hear what I have to say, please. I'm sorry. But people need to hear it from somebody that really experiences it. He was arrested. He's sitting in there right now. And I kept calling up there, and for 3 months, they told me I couldn't come see him. So I began to think, what can I do? Can I do a hunger strike? Maybe I could stand outside the jail? Well, I went to the commissioners. Yes, I did. And I presented myself to them. I presented your model to them, and they listened. And I will be going to see my son on Tuesday. They put him out of restriction. And sometimes being a mother or a loved one, you have to do something. My son is not a criminal. He's a criminal now. He was never had any criminal history, ever. So thank you for taking the time to hear me. I mean, hopefully, God willing. Thank you. I will be moving into my new home in March, so hopefully they'll get him stabilized. He's still incompetent, and get him stabilized and, you know, let him release him, and he can come home. Thank you. Thank you. But the judge, could they do that? Can they go into a mental health facility and remove somebody and take them to jail?
If he's committed, if they think he's committed a crime in the facility and they want to charge him.
And even though it wasn't intentional?
They do it all the time, unfortunately.
Thank you.
So, one, sorry for your personal issue. I mean, it's the stories that we are trying to overcome. The single males are some of the hardest because they're not covered by Medicaid. And so Medicaid is really the #1 source of payment for those with mental illness in the country. And even if you're an expansion state, that population is typically covered. If you're not an expansion state, that's one of the reasons those individuals get passed around, is they're not being paid for under the system. And that's really unfortunate, and it's stuff that we're trying to fix.
And that's one of the things, Steve, I don't think you mentioned, but when you divert your at-risk detainees to crisis stabilization, isn't one of the things you do try to get them all enrolled
We have
in
a
health?
program called SOAR, which expedites federal benefits, and we're able to generally get about 91% of our population that we're screening qualified for benefits in about 30 days.
And that goes back to the IMD exclusion. I mean, ultimately, and your question about how did we end up with so few beds, we built financial incentives not to have beds throughout the system. It's in our Medicaid funding, it's in our insurance policies, it's in all sorts of policies. And if you incentivize people to give them financial incentives not to provide beds, well, guess what? They don't provide beds. And so what Steve's done in Miami-Dade and what we see in some other places, the comment about, you know, it is actually the workarounds for the IMD exclusion. You know, we have to find ways to get reimbursement so that counties and states can afford
and
to
providers
take care
want
of
to
these.
take care of the population.
People want to take care, but we need to pay for it.
Well, we do have to end. Thank you all for coming. I know a lot of you have been personally touched, and the stories are very difficult, and hopefully some of them will have happy endings. And I want to thank all of the presenters for outstanding presentations that are really quite inspiring. Thank you so much.